This is Dr. Julie Huffmeyer with our Open Anesthesia Intraoperative TEE Case of the Month for August 2011. Each month, we will feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. This month, we present the case of a 44-year-old man with a past medical history of hypertension and hepatitis C, who presented with 3 weeks of fatigue, rash, and pitting edema to an outside hospital. His review of systems was also significant for progressive dyspnea, such that he could barely ambulate from bedroom to bathroom without passing out. He also endorsed fevers of increasing frequency and duration. Upon outside hospital workup, his laboratory values showed acute renal failure and severe anemia with an inappropriate response to transfusion of multiple units of packed red blood cells. He also had an echocardiogram which demonstrated a large tricuspid valve vegetation, and his blood cultures were found to be positive for Streptococcus mitis. In addition, his social history revealed intermittent IV drug use with heroin and morphine. The last episode of IV drug use was approximately 6 months prior to admission. This is our patient's preoperative echocardiogram, done at an outside hospital. It is a transthoracic echo image from the parasternal aortic valve short axis view. The right atrium, right ventricle, left atrium, and aortic valve are labeled accordingly. The very large and mobile tricuspid valve vegetation is seen between the right atrium and ventricle. This is the same transthoracic image with color flow Doppler placed across the tricuspid valve. The turbulent flow noted into the right ventricle is likely due to the large tricuspid valve vegetation causing a reduction in the tricuspid valve area. This still image echo shows the two-dimensional measurement of the tricuspid valve vegetation to be approximately 3.8 by 3.1 centimeters in size. The pathogenesis of infective endocarditis involves several steps. The first step in vegetation formation is endocardial injury. This can occur by various mechanisms. Most commonly, injury is due to turbulent blood flow at the coaptation surface on the atrial side of an atrioventricular valve. For IV drug users, direct injection of contaminating debris may damage the tricuspid valve surface. Endothelial damage then triggers sterile thrombus formation with deposition of fibrin and platelets. Once the thrombus has formed, transient bacteremia can seed the thrombus, and blood-borne bacteria adhere to the damaged endocardial surface through adhesins, which are special adhesive properties associated with certain bacteria. Finally, maturation of the vegetation occurs as a result of further fibrin deposition and bacterial proliferation. The vegetation contains primarily fibrin, platelets, and bacteria. There's no vasculature, thus there are no phagocytic cells. While a complete discussion of the diagnostic considerations for infective endocarditis is beyond the scope of this session, briefly, the Duke criteria assimilate information from echocardiography, history and physical exam, microbiology, and pathology to diagnose infective endocarditis. The major criteria focus on microbiological evidence, with organisms cultured from multiple blood cultures as well as evidence of endocardial involvement from echocardiography. The minor criteria include predisposing risk factors for infective endocarditis, such as previous episodes of endocarditis, IV drug use, prosthetic heart valves, and cardiac lesions causing turbulent flow. Other minor criteria are consequences or manifestations of the disease, such as fever greater than 38 degrees Celsius, vascular phenomena such as arterial embolism, pulmonary infarcts, mycotic aneurysms, intracranial hemorrhage, and Janeway lesions, and other immunologic phenomena such as glomerulonephritis, Osler nodes, Roth spots, or positive rheumatoid factor. The Duke criteria were originally proposed in 1994 and revised in the year 2000, and they've been shown to be superior to previous diagnostic criteria. Definite endocarditis requires 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. possible endocarditis is defined as 1 major and 1 minor criterion, or 3 minor criteria. Echocardiography, but especially TEE, provides excellent direct visualization of the anatomy of the heart and the associated endocarditis vegetation and tissue destruction. Transesophageal echocardiography is more sensitive than transthoracic echocardiography to detect small vegetations, intracardiac abscesses, and abnormalities of prosthetic heart valves. There are advantages of transthoracic echocardiography. It is non-invasive and better for right-sided lesions due to the proximity of the right-sided heart structures to the chest wall for visualization. TTE imaging is inadequate in 20 to 40% of adults, often due to obesity, pulmonary disease, and chest wall deformity, which can cause a reduced image quality. TEE is better for left-sided lesions and to further evaluate a less than clear image picked up from TTE. The sensitivity of TEE to detect endocarditis is close to 100% for native heart valves. The updated ACC, AHA, and ASE guidelines report that TEE should be performed when TTE yields inadequate information in patients with a high clinical index of suspicion and for patients with suspected prosthetic infective endocarditis and in elderly patients in whom other valvular abnormalities may obscure the diagnosis with TTE. For patients with possible infective endocarditis by clinical suspicion, echocardiography can help to identify the presence, location, size, and number of vegetations. It can also assess the anatomy and function of the valve involved as well as the other valves of the heart. Echo is also important for interpreting the effect of the vegetation on valvular and ventricular performance, and in identifying other complications associated with infective endocarditis, and providing some data to define the risk of systemic embolization, the need for surgery, and overall clinical prognosis. Vegetations are described as irregularly shaped, discrete, and echogenic masses which are adherent to, yet distinct from other native endocardial surfaces. Mass oscillation refers to the high-frequency motion of the vegetation that is separate from that of other intrinsic cardiac structures. Vegetations may appear to have echodense and echolucent areas within them. The vegetation occurs most commonly on the low-pressure side of a high-velocity turbulent jet of blood flow, usually on the upstream side of the leaflets. The lines of coaptation are the most common sight. On echo, not all intracardiac mass lesions are infective endocarditis vegetations. It is important to exclude calcium, areas of fibrosis, myxomatous valvular changes, and papillary fibromas. There is a strong association between vegetation size and thrombotic risk, such that in some studies the risk of embolization has been shown to be 3 times higher in patients who have a vegetation that is greater than 10 millimeters. Prolapsing vegetations and extravalvular involvement increase the overall risk of heart failure, embolization to the brain, and need for replacement of the valve rather than repair. Please note that each clip is a single cardiac cycle that is looped repeatedly. This may create the appearance of an arrhythmia. The TEE video has also been slowed significantly for demonstration. In the OR immediately before the surgery, this is the mid-esophageal 5-chamber view, so called because it allows visualization of the right atrium, right ventricle, left atrium, and left ventricle, as well as the left ventricular outflow tract. Again, prominent in this view is the right-sided tricuspid valve vegetation. This is the gross image in situ of the tricuspid valve vegetation at the time of surgery. It is easy to appreciate how large and destructive this lesion was. The entire valve was excised and the patient received a tricuspid valve replacement. This is a postoperative TEE in the midesophageal location, 4-chamber view with the TEE probe rotated slightly clockwise in order to focus more closely on the right heart structures, including the right atrium, right ventricle, and the new tricuspid valve prosthesis. Echolucent streaks shadowing down from the tricuspid valve prosthesis are an artifact due to the new valve structure. This is again the midesophageal four-chamber view, now with color flow Doppler across the new tricuspid valve, and it is important to appreciate that there is no residual tricuspid regurgitation and no leaks outside of the valve sewing ring. In order to do this in a thorough fashion, it is important to image the tricuspid valve leaflets at various multiplane angles, but for this discussion only one view is shown. In summary, the pathogenesis of infective endocarditis involves several steps, including endocardial injury, thrombus formation, and bacterial seeding of the thrombus. Diagnosis of infective endocarditis can be quite challenging and involves history and physical examination, echocardiography, often both transthoracic echocardiography and transesophageal echocardiography, and microbiological evidence. The tricuspid valve is a common site for infective endocarditis due to its location as the first right-sided heart valve, and it is the valve most often involved for patients with a history of IV drug use.